Good morning. On behalf of the meeting organizers, I'd like to thank them for the opportunity to present today. The title of my talk is When is Radiotherapy Effective but Underutilized? Using Big Data to Help Us Make Better Treatment Decisions in Lymphoma. Here are my disclosures. I think when you talk about a complex topic with controversies such as the utilization of radiotherapy in lymphoma, it's important to realize there are two sides to every argument. And while a biased medical oncologist versus a biased radiation oncologist may have different answers to that question, hopefully big data can help us provide an evidence-based bridge to the discussion. The objective of today's talk is to review big data sets that support the declining use of radiotherapy when effective, provide practical applications and pointers to the use of big data in clinical practice, and understand some pitfalls in big data. As many of you know, radiotherapy delivery saw a great renaissance in the 1990s and 2000s, transitioning from two-dimensional compensator-based delivery to advanced image-guided, intensity-modulated, even proton-based treatment units. One would then hypothesize that with these technological advances in radiotherapy delivery, that utilization of radiotherapy in lymphoma would have increased over a similar time period. Interestingly, a flurry of big data sets would suggest the opposite, where over the 1990s and 2000s, utilization of radiotherapy declined, and declines of use of radiotherapy in lymphoma were correlated with negative impacts in overall survival. This one, from our group, examined early-stage low-grade follicular lymphoma, a disease where most clinical practice guidelines would support radiotherapy as the preferred option. From the late 1990s through the early 2010s, there was a decline in the utilization of radiotherapy as seen in red, from 24% to 19%, and patients receiving either radiotherapy or combined chemoradiotherapy had improved survival as compared to those who were observed or who received chemotherapy. Our group did a similar analysis using the National Cancer Database in early-stage diffuse large B-cell lymphoma, where we saw an even more striking decline in the utilization of radiotherapy from 47% in 2000 down to 32% in 2012. And in a propensity score adjusted multivariate analysis, again showed that combined modality therapy was associated with improved overall survival on a national level when compared to chemotherapy alone. Others also used the National Cancer Database to show declining utilization of radiotherapy in adult early-stage Hodgkin's lymphoma, with an 11% decline from 1998 to 2010. That was again associated with decrements in overall survival, comparing those who received versus did not receive radiotherapy. And even more striking, in pediatric Hodgkin's lymphoma, there was a 25% decrease in utilization of radiotherapy from 2004 to 2015, which again was associated with a decline in overall survival when you compare patients treated with chemotherapy alone to combined modality treatment. So big data would suggest that on a national level, through the 1990s and 2000s, utilization of radiotherapy in lymphoma decreased across both adult and pediatric subsets, and these declines in radiotherapy utilization on a national level were consistently associated with decreases in overall survival across the most common lymphoma subsites. This big data does raise some important questions. First, are these trends new? If you compare the results for survival within the National Cancer Database from earlier reports in the late 80s and early 90s to more contemporaneous reports from the 2000s, as one might expect, survival for patients who received radiotherapy improved from the 80s and 90s into the 2000s. However, interestingly, despite all the improvements in supportive care, treatment modalities, staging, and workup, survival for patients receiving chemotherapy declined within the National Cancer Database 9% when you compare the late 80s and early 90s to 2000s. This would suggest that these trends are new. However, are these trends unique to lymphoma? I think it's interesting to consider a similar trend where radiation oncologists are on the other side of the trend. The Olsen paradox is a trend described in locally advanced larynx cancer by a well-known head and neck surgeon from the Mayo Clinic, Kerry Olsen. He describes a situation where landmark clinical trials, including the VA larynx study and RTOG 9111, established larynx preservation with chemoradiotherapy as an acceptable alternative for organ preservation as compared to laryngectomy. However, with increased adoption of chemoradiation therapy, it was noted in big data sets, including the National Cancer Database, that increased application of chemoradiotherapy was correlated with a decline in overall survival on a national level. This raises concerns of unperceived selection bias when applying the selection criteria used in the landmark clinical trials to clinical practice, potential for over-reliance on effective salvage, and a lack of appreciation for improvements or patient selection from a surgical perspective when treatment decisions are made outside of the multidisciplinary format. So thus, these trends are not necessarily unique to lymphoma, but why is this happening specifically in lymphoma? If we use early-stage Hodgkin's lymphoma as a framework for understanding if some of the mechanisms noted in the Olsen paradox are also applicable to the utilization of radiotherapy in lymphoma, and focus on the 3 recently published randomized clinical trials looking at PET-adapted omission of radiotherapy in early-stage Hodgkin's lymphoma after ABVD chemotherapy, including UK Rapid, German Hodgkin's Study Group HD610, and EORTC H10. These trials all had variable inclusion criteria, variable designs in terms of numbers of chemotherapy cycles and radiotherapy dose, and despite PET uniformly being performed after 2 cycles of ABVD to assess response, they had variable definitions of PET negativity, which when you combine those factors can give you a very different delta in terms of progression-free survival. Even within clinical trials, if you look at the URTC H10 favorable trial, look at the difference in the delta progression-free survival comparing favorable versus unfavorable patients, highlighting the impact of number of chemotherapy cycles on the potential impact of consolidative radiotherapy. So clearly, interpretation of these factors can have a dramatic impact on how the results of these trials are then applied clinically to an individual patient. It's undoubtable that within clinical trials, patients are typically followed better, and salvage therapy is administered at an earlier time point more consistently. However, even if you look at within the German Hodgkin's Study Group HD16 trial, 13 to 14% of patients had unknown or did not receive salvage therapy, thus consistently relying on salvage therapy for patients who radiotherapy is omitted may not be an effective strategy outside of the context of a clinical trial or even within the context of a clinical trial. Furthermore, the total cost of salvage therapy may not be realized. If you look at an abstract report from the EORTC H10 group, which compared the second progression-free survival of patients who received salvage therapy within that trial, there was no difference in progression-free survival to when you compare patients who received combined-modality therapy versus upfront chemotherapy alone, which could lead to a conclusion that salvage therapy is good irrespective of initial treatment, which might be true, but lost within those conclusions is the amount and cost of that therapy to achieve similar results. If you look at a meta-analysis presented by our group, which is to be updated at this year's meeting, we highlight that in patients who receive upfront chemotherapy alone and do not receive radiotherapy, there's a 3-fold increase in requiring any form of salvage therapy and a 2.5-fold increase in utilization of salvage autologous stem cell transplant. The cost of these salvage therapies, both on the patient and society level, may be underappreciated and certainly could lead to an underassessment of the impact of radiotherapy if not considered in treatment decisions on an individual patient level. And finally, when treatment decisions are made outside of a multidisciplinary format, certain therapies may be overlooked. If you look at the evolution of radiotherapy from mantle field to involved site to involved node, and incorporation of modern radiotherapy techniques such as intensity modulated radiotherapy, clearly, if these decisions are made without radiation oncologist input, the impact of these modalities may be underappreciated. Here, you see within the National Cancer Database, and again, a big data set showing the impact of utilization of intensity modulated radiotherapy in early stage Hodgkin's lymphoma and its correlation with improved survival. An important point that should be discussed and considered, but may be overlooked if radiation oncologists are not involved in those upfront decisions of treatment selection. So, declining utilization of radiotherapy and its impact on potentially negating some of the survival advantages seen could relate to patient selection, over-reliance on effective salvage therapy, and treatment decisions being made outside of a multidisciplinary format. But what are some modifiable factors associated with declines in radiotherapy utilization? If you look at one of our group's reports in the JCO on in diffuse large B-cell lymphoma, focusing on factors associated with treatment selection on a national level, there are a number of factors which may not be modifiable, including race, education status, age, stage, or B symptoms. However, there are some trends that are associated with treatment selection that we could potentially modify. One of which is chemoradiotherapy was more commonly utilized in patients with private insurance, suggesting that well-designed alternative payment models which potentially incentivize utilization of guideline concordant care might increase utilization of radiotherapy in patients with other insurance status. The second is facility type, where you see underutilization of radiotherapy in academic research hospitals, which again speaks to the importance of multidisciplinary care and potential for over-reliance on salvage therapies, which may be more available in academic research type centers. And finally, distance to treatment facility, where patients who live greater than 30 miles from a radiation oncology facility were less likely to receive radiotherapy, again highlighting the importance of advocating for access to care within our societies. So there are some modifiable factors associated with the declines in radiotherapy utilization, including insurance status, treatment setting, and distance to treatment facility. Beyond this, what can we do as radiation oncologists to create data that helps reverse the trends that are implied by big data? So if you look at the trends that were noted in terms of declining utilization of radiotherapy and its reduction in overall survival, interestingly, over the same time periods within these studies, there was noted to be increases in adoption of lower radiotherapy doses, both for indolent and aggressive non-Hodgkin's lymphoma. Clearly, this has an important impact on the burden of radiation when used, as highlighted by this randomized trial from the British group, which showed a reduction in acute toxicity with lower radiotherapy doses without compromises in failure-free or overall survival, both for indolent and aggressive non-Hodgkin's lymphoma. Moreover, radiotherapy has evolved from involved field radiotherapy based on 2D anatomy and bony regions to more modern treatment techniques with involved site and involved node radiotherapy, which means smaller radiation treatment volumes for our patients, which, as highlighted by this retrospective analysis from the Dutch group, contributes to decreases in late toxicity, improvements in patient-reported quality of life, and no compromise in progression-free survival. So if big data shows a decline in radiotherapy utilization, which is associated with negative impacts in survival, and there's increasing evidence to support lower doses in smaller volumes to reduce toxicity and widen the therapeutic ratio of radiation, can we reverse the trends noted in big data with novel radiation-driven trials? The Duke group, led by Chris Kelsey and his now junior partner and my former colleague, Dr. Colin Champ, have championed this potential bridge to taking the trends seen within big data and seeing if we can widen the therapeutic ratio of radiotherapy such that the declines we note in big data can decrease. This is a phase 2 study from the Duke group that looks at reducing radiotherapy dose down to 20 gray in diffuse large B-cell lymphoma, and at 5 years they showed a 98% freedom from local recurrence with a median follow-up of 51 months. This would suggest that decreasing radiotherapy dose may be possible, and by decreasing radiotherapy dose, it's possible that we could then reverse the negative trend noted in the utilization of radiotherapy using more refined imaging and relying on the effect of more effective systemic therapy. This has led to a novel phase 2 design for a multi-center study through the ILROG group, which seeks to confirm the excellent local control noted with reduced dose radiotherapy, which hopefully will help mitigate the declines of radiotherapy seen on a national level. So yes, as radiation oncologists, we can continue to design trials that explore dose de-escalation, incorporation of modern radiotherapy techniques and volumes, which hopefully will help alleviate the negative concerns about utilization of radiotherapy and reverse some of the trends that we are noting on a national level within big data. There are some important pitfalls of big data, and this editorial, written by a famous medical oncologist Harvard, Dan Longo, in response to one of our works, likens our work looking at declines in radiotherapy to a neurosurgeon overly aggressively resecting a brainstem glioma. And while that is an aggressive analogy, he points out some very important pitfalls of big data. The first is any big data analysis has to be considered as a non-randomized retrospective report. Treatment allocation is not random, and it cannot necessarily be accounted for. However, sophisticated statistical analyses can be performed, such as propensity score analysis, which was a component of all of our group's work. Propensity score analysis is an individual patient-level score, which creates a score based on the conditional probability of receiving a treatment with observable covariance. It is unable to account for missing data or inaccuracies in data coding, which is a second pitfall of big data. Inaccuracies in the data recording or ascertainment bias is more difficult to account for because you're unable to assess patient data on an individual patient level. And in fact, it's part of the data use agreement to not try to identify any patients at your center to identify if the data is correct or incorrect on an individual patient level. Factors with missing data can be accounted for through sensitivity analyses, where factors with a significant proportion of missing patients are excluded to confirm the treatment effect. And again, while treatment details and important things such as number of chemotherapy cycles, type of chemotherapy, or response are not available within this data set, and you rely on large numbers to hopefully obviate that. And finally, at least within the National Cancer Database, there is no reporting on cause of death. And you rely on overall survival as your surrogate, which can be problematic in diseases such as indolent lymphoma, where patients have competing risks of death against an indolent malignancy. So while big data is useful, it may fall short in lymphoma when you think about the way trials are being designed and interpreted. The SWOG S1001 trial, recently reported in the Journal of Clinical Oncology, is a prime example. It looked at PET-directed omission of radiotherapy after three cycles of R-CHOP, and the authors conclude that the trial establishes R-CHOP times 4 as a new standard approach to limited-stage disease for the absolute majority of patients. You'll note that in the trial design, there is no comparison plus or minus radiotherapy for those who have a complete metabolic response after 3 cycles of R-CHOP. And devoid of their conclusions is the impact of radiotherapy in salvaging patients who are PET positive after 3 cycles of R-CHOP, where in the survival curves there's overlapping results for those who receive 3 cycles of R-CHOP plus involved field radiotherapy for interim PET positivity compared to those who are interim PET negative. Finally, we would conclude then that big data clearly shows concerning declines in radiation and lymphoma are associated with declines in overall survival on a national level. These declines are new, they are not unique, but they are related to some modifiable factors to reverse trends, and continued study and interest in lymphoma is imperative to improve outcomes for patients. I'd just like to conclude with a patient quote. I think it highlights what our patients are feeling in terms of the trends we are noting within big data. The patient emails me, this is a patient email of a patient I've never treated. She says, I read your comments as a Pittsburgh native, a graduate of Pitt, and a non-Hodgkin's lymphoma patient with interest. In 1998, I was diagnosed with non-Hodgkin's lymphoma marginal zone, and at that time we were living in Boston, so I had treatment with Dr. David Fisher and Dr. Peter Malk. I was treated by Dr. Malk 11 times with low-dose radiation and felt very blessed each time I had good results. I was treated twice with fludarabine and Rituxan when I had multiple sites, but that wasn't as successful as radiation. My last radiation treatment with Dr. Malk was in 2015. I switched my care because he became terminally ill with a rare cancer. So unfair. I truly miss Dr. Malk, who was not only a great doctor and a great human being, and I'm thankful he believed in low-dose radiation as the best course. I agree with your article, as many others I have known with non-Hodgkin's lymphoma were directed to have chemotherapy as opposed to radiation because they were under the care of an oncologist. I feel very fortunate Dr. Fisher and Dr. Malk work as a team and decided the treatments together. And with that inspiring email, I will conclude and thank you for your attention. I'd like to thank the session organizers for generously inviting me to present today, and all the people who have collaborated with me on lymphoma projects over the years. Thank you.